Hello, I am Dr. Atulabh Vajpayee. I am Professor and Head Neurosciences, Pacific Medical College, Udaipur. Stroke, by and large, is second common cause of death in our country. It is leading cause of disability in our country. There has been many challenges for acute stroke treatment in our country, primarily because of three reasons. Number one, lack of public awareness. And secondly, there has been superstitions and myth around stroke treatment. So there has been many people, especially in tribal and rural area, who are going for faith healing, pigeon blood massage, and alternative medical managements. On the medical community side, there has been lack of adequate infrastructure and manpower for treating this problem. Thirdly, on the government side, there has been wonderful initiative for health ailment coverage by government, be it central level or in my state also. But so far, there has not been adequate coverage for covering acute stroke therapies like mechanical thrombectomy from the government side. There are various risk factors for stroke and heart attack. Some of them are non-modifiable like age, sex or race. Then there are some modifiable risk factors, what we call low-hanging fruits, which you can actually modify and prevent the occurrence of all such problems like smoking. You can quit smoking and reduce your risk factor for having these ailments. You control your blood pressure well, you control your sugar well, you change your lifestyle from sedentary to more active to doing regular exercises at least half an hour to 45 minutes every day. So these are the risk factors you can modify, and of course along with that, controlling your cholesterol level. So these are the risk factors you control, modify them, and you can prevent. Along with that, there are certain lesser known risk factors like your dietary habits, like your hygiene maintenance, because this is what a new paper we published called Vidra as a risk factor for stroke prevention. So because we found that there are infections which are involved in genesis of heart attack or stroke, which are not directly causing these things, but through other immune mediated problems or through various other mechanisms they have been responsible. So commensals in and around our body has been responsible for genesis of stroke or heart attack in some of the patients where we are not able to find out any specific attributing risk factor to stroke or heart attack. Then there is of course one thing which is often missed and underdiagnosed is sleep apnea as an independent risk factor for stroke. Sleep apnea and stroke, there is a complex interplay. Obstructive sleep apnea is an independent risk factor for stroke, like in 20% of the cases. Now, how does it lead to stroke or heart attack? You see, in obstructive sleep apnea, when you are sleeping in night, because of narrowing of your air passages, there is reduced perfusion to your brain, there is reduced oxygenation to your brain. And because of this, there is surge in stress hormones, and we all know that due to this surge in stress hormone, there is hypertension, there are tachyarrhythmias, and especially atrial fibrillation. So as we all know that OSA per se leads to three-fold incidence of atrial fibrillation, and we all know that atrial fibrillation is an important risk factor for causing stroke. Then secondly, persistence of OSA, it needs to be diagnosed because it worsens stroke outcome. Somebody who had this as a risk factor during the treatment of stroke also, if you don't pick it up, then it will worsen the outcome in terms of stroke morbidity and mortality at 1 month and 3 months. So there are various studies supporting this thing. And thirdly, as high as 50 to 60% patients will have obstructive sleep apnea after stroke. So that is, it could be because of both ways. Some of them are central, some are obstructive sleep apnea type, but 50%, as high as 50% patients will have OSA after stroke. So you need to pick it up, because many times you are treating a stroke patient, he recovers, and later on patient comes with you with the fatigability, excessive daytime sleepiness, lack of concentration, lethargy. So all these symptoms, if you are not looking at obstructive sleep apnea, then you are liable to miss them and you cannot treat this patient adequately. So a simple therapy, but as I said, obstructive sleep apnea, for that matter any sleep disorder, are highly underdiagnosed. What we see and diagnose is only the tip of the iceberg. So we need to pick them up in time so that we can actually add better quality of life to our patients. Primarily there has been three major advancements in acute stroke therapy over last 1 decade or so. First of all, there has been an advent of clot busting drug IVTPA, which has to be given within first 4.5 hours in acute stroke patients. Second has been use of mechanical thrombectomy or aspiration, which is using a stent retrieval device in the brain arteries if they are clogged with the thrombus and removing that debris out. So this mechanical thrombectomy has to be done within first 24 hours. Third has been putting up stroke units in various places. So this is by far, if I have to put my money on something, I'll do it for putting up acute stroke unit. This is more of HDU kind of setup in hospitals, which is a dedicated stroke patient area. So here, taking care of simple things like controlling their blood pressure to right degree, maintaining their fluid level in the body or their calories in the body, doing right kind of physiotherapy or posturing. So these small things make a big difference in outcomes. So this staff precisely know what is to be done with the patient. You don't have ventilators in stroke unit, but you have dedicated staff who is well versed with treatment of stroke patients, because any kind of small maneuver would lead to better long-term outcome, and this is evident from many studies. We do have enough literature that presence of a stroke unit does affect stroke outcome.